Now we will explore syphilis testing options in more detail. In this lesson, you will learn the different types of tests used to diagnose syphilis. You will be able to list examples of treponemal and non-treponemal tests and describe why they are both needed for syphilis diagnosis, and you will be able to explain some potential causes for discordant lab results. Syphilis cases are classified as probable or confirmed for surveillance. There are only two tests that meet the confirmed classification for syphilis, and they are the dark field test and the PCR test. Both are rarely performed. Dark field microscopy involves direct visualization of the T. pallidum bacterium from a skin or genital lesion. Dark field microscopes are pretty rare, but the Maricopa lab does have the capacity to run this type of test. Dark field tests will only be reactive if someone is in one of the symptomatic stages of syphilis, and these tests are not recommended for oral lesions. Serological tests are the most common types of tests used to diagnose syphilis, and they are split into two categories: non-treponemal and treponemal tests. In a non-treponemal test, you get both a qualitative test result, either reactive, non-reactive, or indeterminate, and you can get a quantitative result, a specific numerical value in the form of a titer. Non-treponemal tests include the RPR and the VDRL. Typically, the specimen used for these tests is a blood sample extracted through venipuncture or cerebrospinal fluid. These tests can not only tell you if a specimen is reactive, but the laboratorian can and should always run a titer. The titer is a quantitative result that can be monitored to determine if someone has been reinfected or if they have had an appropriate treatment response. If you are monitoring titers, note that you should only compare RPR titers to RPR titers and VDRL titers to VDRL titers, since there is likely to be a variation between the VDRL and the RPR titers that is unrelated to the syphilis infection. Titers can fluctuate widely, so it is important to always get a day of treatment titer. Individuals will likely remain positive with lower titers for the rest of their lives. We refer to these follow-up test results as serofasting. We will explore titers in more detail in the next section. There are many types of treponemal syphilis tests. The TPPA is the gold standard. However, many laboratories are using immunoassays like the EIA, CIA, CLIA, and MFI because they are cheaper and easier to batch. The specimen type for this test is also blood. The treponemal tests are used to verify a syphilis diagnosis. For surveillance, unless you're in a primary stage, you have to test positive on both the non-treponemal and the treponemal to meet the case definition for syphilis. Most people remain positive even after treatment, and the test cannot be used to monitor treatment response. Though less common, about 15 to 25% will revert to negative. If someone becomes reinfected for syphilis, having a fourfold increase in their titer, technically you would not need to run the treponemal test since most people remain reactive. So a case with a TPPA reactive from 2019 who does not have a recent TPPA but had a fourfold increase in titer this year would still meet the case definition for a reinfection, even though they do not have a current treponemal test. It is best practice for a provider to order a syphilis screening cascade that will automatically reflex to a second test if the first is reactive. Remember, both the treponemal and the non-treponemal use a blood specimen, so it is possible to run both tests using one blood sample. This screening cascade will also include a tiebreaker test if there are discordant test results. There are several labs that offer screening cascades. Please keep in mind the test menus and codes may change, but here are some examples of cascade options that were available at the time this training was created. There are also rapid tests available for syphilis. The rapid test can be performed using a finger stick, which is advantageous in settings where venipuncture is not possible. Persons with reactive tests will need to be referred for confirmatory testing. Rapid syphilis tests are not specific, so if a person has a previous history of syphilis, the rapid test will not distinguish between historical and current infections. This is a screenshot of a resource that is available in the Investigator Toolkit. Since we need 2 reactive tests to determine if someone is infected with syphilis, we have 2 options for the order in which those tests can be performed. Using the traditional screening algorithm, a lab would start with the RPR. If non-reactive, no further testing would be performed. If reactive, a treponemal test like TPPA would run. If the TPPA is reactive, syphilis is likely. If it is not reactive, syphilis is unlikely. The second testing cascade option is the reverse algorithm. With the reverse algorithm, you start with a treponemal test, usually an immunoassay like EIA or CIA. If the treponemal is negative, no further testing would be performed. If the treponemal is positive, a quantitative RPR would be run. If the RPR is positive, you have a case of syphilis. If the RPR is negative, it reflexes back to a different treponemal, usually a TPPA. If the TPPA is positive, you have a syphilis case. If the TPPA is also negative, then syphilis is less likely. Let's take a closer look at reasons why you might get discordant labs. Discordance is when the results of 2 or more tests do not agree, i.e., the person has a positive treponemal but a negative non-treponemal test. There are many things that can cause discordance. The person may have a history of syphilis infection, either treated or untreated, or they may have another co-occurring condition that triggers a false result. With the exception of primary syphilis, syphilis cases must have both a reactive treponemal and non-treponemal test to be counted as a case of syphilis for surveillance purposes. The only stage of infection in which a single reactive test would be sufficient for the case definition is primary syphilis. If a chancre is present and there is at least 1 reactive result, regardless if the other test was negative or not performed, a person can be staged as primary and counted as a case. It can take time for a person to seroconvert to positive on both tests, and it is possible for a person in the very early stages of infection to have a false negative on one or both of their syphilis tests. If there is a concern of recent exposure, i.e., they have been named as a contact, then it is recommended that the patient receive both preventative treatment and syphilis testing. Since it is possible to have a false negative result while incubating, i.e., prior to the onset of symptoms, contacts should receive preventative treatment regardless of test results. If the results are positive, the contact becomes a case, and they should receive partner services so that their partners can be referred for testing and treatment. In addition to false negative results, clients can have a false positive result. There are several morbidities and conditions that can trigger false positives on both the treponemal and non-treponemal tests, which is why it takes both to classify a case. Chancroid, chickenpox, and hepatitis are just a few of the conditions that can cause a false positive on a non-treponemal test. Cirrhosis, leptospirosis, and malaria can cause a false positive on the treponemal test. Advanced age, brucellosis, certain immunizations, leprosy, Lupus, pregnancy, and other spirochete infections like Pinta and Yaws can cause false positives on both the treponemal and non-treponemal tests. There is a resource in the investigator toolbox that outlines possible causes of a biological false positive in more detail. For persons who are pregnant who have discordant results, we recommend retesting in 4 weeks due to the rise of congenital syphilis in the number of persons infected and reinfected during pregnancy. In this lesson, we have discussed the difference between confirmatory tests like dark field and PCR and non-specific serological tests like treponemal and non-treponemal tests. Due to the non-specific nature of the serological tests, you learned that both a treponemal and a non-treponemal test are required for most syphilis diagnosis, with the exception of primary syphilis. You learned that both treponemal and non-treponemal tests can be run using blood, and they can also be run in a cascade where a reactive initial test will trigger the second test type to run. We also discussed the types of things that can result in discordant results, such as history of syphilis, an early infection, or a false positive. And finally, we learned that pregnant persons in Arizona with discordant results should be retested in 4 weeks.